everyone. Samantha serves as the Deputy Director of the Bureau of Prevention Services at the Illinois Department of Human Services Division of Substance Use Prevention and Recovery. And I think you guys probably saw the rest. I'm not going to read the whole thing. This was part of the flyer. So for today, you can go to the next slide. We are going to be giving one contact hour. Please fill out the survey for us. This helps us collect more data that we're doing, and is super helpful for us. So you will receive a contact hour as long as you fill out that evaluation at the end. While the content, you can go to the next slide. While the content is geared towards the perinatal population, it does apply to everyone. I know we have some ED people on, so just know that while there is a lot of content geared towards that population, it still applies to everybody. So really, we're here today to talk about the Drug Overdose Prevention Program. This is a grant-funded program in Illinois through the Illinois Department of Human Services for organizations and hospitals to provide take-home naloxone to patients and or their friends or family members at risk for overdose. This includes patients who not only have opioid use disorder, but are being discharged home on narcotics. In the past and currently, prescriptions have been written for patients, but they're not commonly filled. It's pretty rare that they're actually filled. So the goal really is to give patients take-home naloxone. This is a form of harm reduction by decreasing the chance of overdose, decreasing unsafe drug use, and improving the chances of people seeking treatment and recovery. I'm going to hand it over to Samantha. We'll go to the next slide. And she's going to present for us, and then we'll talk about the DOPP program and some updates to it and how to sign up. Go ahead, Samantha.
Thank you, Hannah. The slides I'll be covering are about the intersections of substance use, maternal health inequities, domestic violence, and community violence, just showing how these issues are all interconnected. And so I want to encourage you all to take care of yourself because this presentation may trigger some people and help is available if you need it. So you're welcome to share these slides after the fact, but here's the Illinois Domestic Violence Hotline, the Illinois Helpline for Opioids and Other Substances, 988 Suicide and Crisis Lifeline, the NAMI Helpline for Mental Health, and then a link to additional violence prevention and support resources. Next slide. So when I talk about these different issues, I joke on the right side that this is how I look at the issues of how they're all interconnected, kind of like I'm putting the yarn between these different issues of maternal health inequities, substance use, and violence. And so before we can really look at preventing violence or substance use, we have to look at what the root causes of those two things are. And often the underlying issues are adverse childhood experiences, so childhood trauma. That includes witnessing domestic violence, experiencing child abuse and neglect, or having substance use in the household, racism, including racial trauma, environmental racism, systemic and structural racism, and interpersonal violence, such as community violence, domestic violence, or suicide. Next slide. There are a couple of people unmuted. Please mute. Thank you. And so how does this relate to maternal health inequities? Well, when we look at the leading causes of pregnancy-related deaths, substance use disorders are the leading cause in Illinois from 2018 to 2022. And then up there within the top 10 causes are also mental health conditions, suicide, and homicide. And all these things are influenced by intimate partner violence. So we do have to consider how all of these things influence the maternal health inequities. Next slide. And for those of you who may not be familiar with adverse childhood experiences, the original ACEs study, so that's ACEs for short, focused on 10 domains that happen within your household, these different events and experiences that influence having childhood trauma that can affect you long term. And when looking at those original 10 domains, which are focused in this first realm of ACEs, the household, they looked at whether those exposures to childhood trauma influenced your long-term physical and mental health outcomes. And what they found is if you had four or more of these, you were likely to have a wide range of negative physical health outcomes and more likely to die earlier, to have chronic health conditions, and have a wide range of negative health outcomes. And that was in the original ACEs study. But then there has been more recent research that has acknowledged that there are community and environmental adverse childhood experiences. So, community can include exposure to structural racism, discrimination, violence, housing insecurity, food insecurity, poverty, and so on. And then environmental can include things like if you're in a community with high pollution rates and all of us lived through the COVID-19 pandemic. And so that was a collective trauma for a lot of us. And the thing is if you have been exposed to violence, if you've been exposed to adverse childhood experiences, then a lot of times what we see is that violence begets violence. And so if you've been exposed to domestic violence, you were personally harmed or you witnessed a parent being harmed, then you're more likely to become a victim or perpetrator of domestic violence later in life. You're also more likely to become a victim or perpetrator of community violence. And then the cycle continues over and over again unless we do something to disrupt that cycle. Next slide. And so, where do we see these increases of these negative physical health outcomes? We see that across a wide range of health issues. And so, if they're exposed to high doses of childhood trauma, then it can triple the lifetime risk of heart disease and lung cancer and result in a 20-year difference in life expectancy. And the higher the ACE score, the more likely adults are to experience a host of negative consequences, including the following: being 1,220% more likely to attempt suicide, 1,003% more likely to inject substances, 460% more likely to have recent depression, and 400% more likely to have an alcohol use disorder. And on top of that, Black women experience weathering, where they experience persistent toxic stress from racism combined with sexism, also called misogynoir. And so we see disparities in maternal health, maternal mortality as well. So this image on the right, this graph just shows that there are significant racial disparities and that Black women disproportionately die at higher rates compared to their white counterparts. Next slide. And so when taking a step back and looking at how all these issues intersect, like we have to acknowledge the impact of birth trauma and maternal mental health and how that influences physical maternal health outcomes. And so looking at births in general, 1 in 3 births are traumatic. So even if you miraculously make it to the labor and delivery room and have never experienced trauma in your life before, you've managed to go unscathed, which I believe is extremely rare, then you might have a traumatic birth experience that can stick with you long term. And then 1 in 6 women who've experienced abuse were abused for the first time while pregnant. And up to 15% of these women who've given birth develop postpartum depression. And some studies established a 20 to 25% prevalence of anxiety disorders during pregnancy and 15 to 20% in the postpartum period. And about half of pregnancies are unintended, some that were resulting from rape, including through intimate partner violence. And so understanding that sometimes people they're giving birth through an unintended pregnancy, and they may have been abused that influenced that pregnancy. And then that may also be why they're turning to substances to cope with it, or maybe they never intended to get pregnant in the first place and were already using substances. And so this image on the right shows common trauma responses, which I used to work in healthcare, and every healthcare provider I know has seen these multiple times, especially in the context of an emergency room, but I'm sure also in obstetrics and gynecology. So a lot of people have heard of fight or flight, where someone may appear as aggressive or argumentative, or they may seem like they want to run away, or They look anxious. But there's also the trauma responses of freeze or fawn. So freeze, they may have a hard time speaking and responding. They may refuse instructions and want to be alone. And they show like physiological responses to being overwhelmed and anxious. And then there's also fawn, where that may mean like wanting to please people and saying yes to everything, even if they don't want to, over apologizing and scared of saying what they actually think. And these are really also survival reflexes that people who've experienced trauma do these things to survive. Next slide. And so, what are steps that we can take to address these intersectional issues? First, we can identify those trends of those issues that are connected, like the ones I just talked about. And we can advocate for and deliver trauma-informed and culturally appropriate services. We can also collaborate with people with lived and living experience and other organizations that focus on these different topics and foster more supports for people with lived and living experience at the individual and systems level. Next slide. So I will pass it back to Hannah, but then also welcome questions later on related to the drug overdose prevention program.
Perfect. Thank you so much, Samantha. And that topic on trauma-informed care is very near and dear to mine and Autumn's heart. And we're actually doing another webinar on Monday that really goes into more detail on trauma-informed care in the perinatal setting. So I invite you to attend that as well if you have not signed up, and we will put the link to that in the chat at the end. And then we will do questions at the end as well. I know Autumn put that in the chat in case you didn't see it. Some of the questions you may have right now probably will get answered in future slides, and if they don't, we will have time at the end for those. I just wanted to talk a little bit about the naloxone project and what that is. And I know we have the co-chair of the naloxone project on, as well as the national project manager. So please feel free to interject at any time if you have something to add. So the naloxone project is a 501c3 organization. Started out in Colorado, is now in, I believe, 12 states. The Illinois chapter just launched in May. Here in Illinois, they're working with IDHS to improve hospitals' involvement in DOPP. And I've had the opportunity, as well as Autumn, to be a part of this committee and be involved in the great work that they're doing. So like I said, while our slides are targeted towards the perinatal population, all this information does apply to anyone who's at risk for overdose. Next slide. And I'm going to hand it over to Autumn now.
So like Hannah said, we're going to kind of talk a little bit more about the maternal portion of this, but I also want to understand that when we look at like the state of Illinois, and we have a slide of that coming up, like I don't want ED to think like, oh, this is all labor and delivery, but there's a lot of hospitals in Illinois that actually don't have birthing facilities. So this is very much applicable to you as much as it is to labor and delivery units. So when we look at national statistics related to maternal death, nationwide, it says between 2017 and 2020, 1 in 6 pregnancy-associated deaths were due to an overdose. If you look at these two graphs down here, specifically, we see a very big influx in fentanyl use, which actually, if you look at the maternal mortality report in the state of Illinois, I hope that you guys are all familiar with that. If not, I'm actually going to throw that in the chat so you can look at that of what our data shows, but it's very similar to in the state of Illinois. Fentanyl is the number one substance that is used and leads to maternal death from overdoses. And then if you look at this graph on the right, it just shows like when the highest rates of it are. And you can see there's a pretty steep increase of the use during pregnancy and then also during that late postpartum period. And a lot of like the MFMs or physicians that we work with, we talk about that like this is like a window of opportunity, right? Where patients are stressed, they're overwhelmed, but some of them are like, I really want to get better, I really want to take care of myself. But then we see some people on the other end of the spectrum who are like self-medicating, whether it's with fentanyl, alcohol, right? Or, other substances. So statistically, those were national statistics, but if you look here, this is comparing Illinois to the whole United States. Illinois statistics and graphs, I think, are pretty similar to what you see nationally. And I think another important thing to point out is that it says that overdose is one of the leading causes of perinatal deaths. If you look at the statistics from the maternal mortality report, Illinois came out in October of 2023. It shows that the highest cause of maternal mortality was substance use disorder, and that was sitting at 32% of maternal deaths were substance use. And then the next leading cause of maternal death was cardiac disease or cardiac issues, and that was only sitting at 14% of deaths. So if you can imagine, substance use is more than double, essentially, of what the leading cause of death is for our pregnant and postpartum patients. So this is the map that I was referring to when you look at the state of Illinois, and it says, does your ED distribute naloxone to high-risk patients? This is specifically just focusing on EDs. And if you look at this, I mean, 77 of the hospitals in the state of Illinois said no. So really our goal with the naloxone project is we would love to see the state turn yellow, and we would love for this to say yes. We would love to see the EDs hand out naloxone, but also because of this increase or influx that we're seeing in maternal patients, we also want the perinatal units to be handing them out as well. So like labor and delivery, postpartum, involving the NICU in that as well. If the NICU has a patient who is at risk, we want everyone to be able to have access to that, and not just the EDs, but a collaborative effort to help make this yellow so we can make it more accessible to patients who need it. So, oops, I think I went backwards. Sorry. So it said, who should receive naloxone? And this is like one of the biggest questions that I feel like at least I've been getting from hospitals when I talk about the DOPP program. And I'm not going to read through all this to you, but essentially anyone who has a history of opioid use, maybe has had a relapse. Also, if like their partner or their support person or someone they live with has opioid use disorder, it's not necessarily like just the patient. So it's like anyone who could be around that patient. It even says anyone who's getting a new opioid prescription for pain. So we still see that question of like, well, you know, they had a C-section, so they're getting it. Yeah, but they are still at risk for an overdose, even though they might not have an overdose or a substance use disorder at the time. They're still being given an opioid. So I really do feel like there's a lot of like cushion. It's really about getting the Narcan out in the community to patients to help prevent and kind of help slow down, right, the risk of overdose that we're seeing within the state of Illinois. So this is an example of what the DOPP program provides to the hospitals. The amount that you would get varies, and I'll let Hannah and the rest of the team kind of talk about that in a little bit, but this is essentially what it looks like. It would be just be a box with two different Narcan nasal sprays, which are located within the box. And then it has the handout, obviously, based on the education. There are a ton of resources too available to you guys as staff on how to educate them and how to use it, when to use it, etc. But knowing like where you would store it, some people say they store it in their Pyxis, other people have it like with pharmacy or some other way to distribute that. But just kind of thinking about if you guys, you know, when you move forward with this, where do we think it would be easiest to keep it on our unit or within our facility? So what does the naloxone project have to offer each hospital site? And really by joining this project, the goal for us is to provide you guys with free of charge toolkits and materials and assistance to help you guys be able to implement take-home naloxone kits. Now, I think that's an important thing to remember. These are take-home Narcan kits. This isn't necessarily your Narcan that you're using on the unit or inpatient. These are Narcan kits that we want to go home with people out into the community, into those spaces where there could be a risk of an overdose. And then really the goal too, another thing is that we're here to help you guys, which is why Hannah and I thought doing this webinar would be really helpful, because I think Hannah and I have done some surveys of the hospitals throughout the state of Illinois, and a lot of people are saying that they feel overwhelmed by the process and they don't know how to register or what this would look like for their institution. So really we're here to help show you guys the significance of the problem within our state, and then how we all as at the Naloxone Project want to walk alongside you and make this more easy to do. And I'll hand it, I think, back to Hannah.
Yeah. Okay, so we're going to talk about becoming a DOPP site if you are not already one through the Naloxone Project. So with the Naloxone Project's help, and what does that look like? So we'll talk about how to enroll in DOPP, and Samantha has made a really nice video that we'll watch towards the end. But if you decide you would like assistance from the Naloxone Project, They have an enrollment form that you can sign. It's pretty quick. And then they provide all these resources to you. They can have one-on-one meetings with you, and Autumn and I have been helping with that as well with hospitals that we're connected to. So they have sample policies. It's recommended to have a policy on this, and then really have involvement with your pharmacy team. And then again, like Autumn had already said, talking about how you're going to build this into your electronic medical record. So that, hopefully these things shouldn't cause barriers, but just discussion so that it can be implemented well. And then of course, education. So some of this stuff seems really intimidating. And I think when people read it, especially the wording that has historically been on the site has come across as intimidating and just too much to handle. But it really is simpler than it seems. And like I said, the Naloxone Project has video links. So it could be as simple as playing a video at your staff meeting, and that's your education. So next slide, please. Yes, and Samantha put in the chat that they've updated and simplified the info. So we're going to talk about that. And then, of course, the way that you report data has been very much simplified. So this is our, actually, all these people are on right now. So when we do Q&A, they might be a good person to answer depending on what your question is. So I'm super happy that they're on. But Steve Holtzford, Dr. Holtzford, and Tran are our co-chairs for the Illinois chapter of the Naloxone Project. Tran has a pharmacy background. Dr. Holtzford has an emergency medicine background and is also an addiction medicine specialist. And then Nikki King is our national project manager. So she is a wealth of knowledge and has a social work background because she has done this with all of the states that started in Colorado. Next slide. Okay, so how the sign up process. So how do I register to be a DOPP? So you would go onto the website, which we can throw in the chat where you would go to get there. And then you would click on this page, hospitals and clinics, access Narcan, unless you're a community organization, and then you would click on that one. It then pops up with a SurveyMonkey form. About a week after completing the form, you will get an email on how to set up your account. It's pretty straightforward. And then you would receive an email from the manufacturers of Narcan. Next slide. So then you would get an email from Emergent Biosolutions. It has all the instructions once your account is set up. Emergent, actually, they'll set up a meeting with you if you wanted to do that. They talk about, they actually also have resources. They have like training materials. So again, the Naloxone Project, Emergent, they both have free resources for you. And then order requests will be sent to the Illinois Department of Human Services. When you get to this step of ordering, something that I learned is that it will have like a dollar amount, and it almost, I think so. I've heard that some people get tripped up over this and think, well, I have to pay. It has a dollar amount, but it is never going to ask you for payment. You just click next and keep going, and it places the order. And then these typically ship within 2 weeks after it is submitted. Next slide. And now we'll talk about the data collection. So I think in the past, this has seemed very overwhelming, especially for smaller hospitals that maybe have a one-person pharmacy team, don't feel like they can take it on. This is literally should not take more than 1 minute. The ask is to complete it monthly, and you would be selecting basically your zip code and your county, and then how many did you hand out? And that's it, because the ones that you would be handing out are the nasal spray 4 milligrams. So this shows you where that is, and we'll show a video on that. And I think, is it time to show the video?
Yeah, it's time to show the
Okay,
video. So let me just X
okay.
out of here. Sorry, the video wasn't. Can you guys all see it?
I had it embedded and then I guess it didn't work. So
Can you all see this?
yeah, we can see it.
Okay, just let me make sure that the sound is going.
So I'm Samantha
Yep.
Lanis, the Deputy Director for the Bioprevention Services with the Illinois Department of Human Services Division of Substance Use Prevention and Recovery. And I'm going to do a mini training to show how to use the healthcare form within the Illinois Saves Overdose reporting portal. So once you log in and you see this screen, you'll click the forms drop down, and there is now a new form here called Healthcare Distribution Form, which you'll click. You'll then select the site for which you're reporting, then the distribution county location. So in this example, I'll use Cook County, and then distribution zip code if known. And please do enter this if you do know the zip code to improve the integrity of our data. So I will just start typing in, and it does have predictive text, and I can select whichever zip code it applies. And then I will select the month of distribution because we are asking our healthcare providers and clinics that are enrolled in the drug overdose prevention program to report on at least a monthly basis. And so you can report for an entire month of distribution at a time. And please report it by the 10th of the following month. So for example, if I were reporting for September in 2024, I should submit that data by October 10th, 2024. So let's say I was submitting for September 2024, I select that month from the dropdown, and then I select the year. And then I scroll down and I just enter how many naloxone kits I distributed within the month for which I'm reporting for this given site. And so in this case, let's say I were reporting that I distributed 100 nasal sprays that are 4 milligrams, and perhaps I didn't distribute any other formulation, and that's all I have to enter there. And then if I want, I have the option to submit notes here. Once I've filled out those fields, then I can click submit. You should then get a message such as this one that says, thank you for your submission. Your data has been received. If you have more data to enter, use the navigation links above. And then you could just go back and enter more data if you needed to enter it for separate sites, for example. If you do have any questions about how to navigate this, you can contact the DOPP coordinator at dopp.coordinator@illinois.gov. Thank you.
Okay, thanks. And I see, yeah, we can do some Q&A. I do see some questions in the chat about requirement for education. Before I go to Q&A, I just wanted to emphasize, if you are on and you are already a DOPP, I know sometimes with the survey that Autumn and I did, it was like, yep, we're a DOPP, we're good. Just ask yourselves, you know, like, okay, if your ED is registered as a DOPP, you know, are you, and you're a perinatal unit, are you sharing that with them? Are you aware of how, like, the process for that, and are you utilizing it on the unit? I feel like EDs and OB units tend to work in silos from each other, and so this is an opportunity to really connect with them. You don't need to obviously sign up as a DOPP if your ED is already signed up as a DOPP. Really have to collaborate together and implement it on your unit. And then really thinking about an opportunity in the NICU. I know that Autumn talked about that a little bit with including NICUs in this. But if we think about it, like, we could potentially miss patients in OB. We really see these patients for such a short amount of time, and it's a very intense time. You know, they're going through labor and delivery, and it's everything is fast and intense. So it's really something that could get missed. Whereas if someone's baby goes to the NICU, first of all, like Samantha was talking about, anyone whose baby goes to the NICU, that's traumatic, right? So it's important to recognize that, even though that this is our everyday. But knowing that in the NICU setting, we are seeing these patients on a much more long-term basis, whether it's a week or like almost a year in some cases. This is an opportunity to identify patients that are at risk and utilize and implement Narcan distribution in the NICU setting. Because while the babies are the patients, the whole family really is who we're caring for, and who the baby is going home with those parents. So I just wanted to kind of end with that thought, and we can open it up for Q&A unless any of our co-chairs from the Naloxone Project or Samantha have anything to add before we move to Q&A. So I do see, I'm just going to look at some of these questions. Richard said, I thought I had seen that there was a requirement to report training/education. Is that no longer needed? Samantha, I'll let you speak to that.
Sounds good. I think a lot of these questions are going to be for me to start off with.
Yep.
But so we completely changed the reporting requirements for healthcare institutions, for hospitals and clinics. So before, hospitals and clinics would have to submit 2 spreadsheets to us of data and depend on their electronic medical record systems to gather some of that data. And we recognized that wasn't very user-friendly. It wasn't intuitive.
Yeah,
And so we
the whole time. Look at her.
I also got muted. So then we very much simplified the reporting process now, where all we expect hospitals and clinics to report to us is how many kits you distributed per month. And we do not expect you to report on training and education to our program. We still hope you are delivering some sort of training and education, but we don't need you to report that. We're assuming that if you're handing a naloxone kit to someone, you're at least providing some information about how to recognize the signs of an overdose and how to respond to it. So you do not have to report training and education to us. You're only reporting the number of kits that you distributed per month. And then I'm going to answer 2 questions ahead because it's related to this. Is there a reporting requirement for specifying number used for each unit, ED and OB? For example, if Narcan distribution is overseen by pharmacy, I think that is, for our program, I'll answer, we don't need you to break that down unless you have registered different sites for your project. So your hospital may be registered as a project. And if you added different sites for different departments, then you would want to report the different site data. But if you didn't do that and everything's at the project level, you're just reporting as one hospital, we do not need that. But then I would ask like the other folks if they have an answer about like if the hospitals would require any different reporting based on the department.
Okay, and then I think there was one question up here. How does the DOPP program differ from the naloxone distribution programs through local health departments?
So the main difference is probably those local health departments are often getting their naloxone from us or from the Illinois Department of Public Health and distributing. And so it's fine with us if hospitals have a relationship with the local health departments instead of enrolling in the DOPP themselves. But if you want to be able to have more control over that and order naloxone and distribute and then report directly to us, then you can enroll in the drug overdose prevention program and take away the middleman of having to do that back and forth with the local health departments.
Okay, perfect. And then a question about if an OB unit enrolls in the DOPP program, is it then opened up and offered to all patients in the entire hospital, or would they just keep it with their OB unit?
That may be a hospital level policy to determine. To us, if you're ordering, if you have a DOPP project, you're enrolled in DOPP and you're ordering naloxone, you're just reporting to us what you distributed per month. And so we wouldn't know the difference of if you're reporting to the OB unit or to other parts of the hospital. So that may be based on like your hospital's policies and if they restrict that. And there was a question above that, so I want to just make sure we don't missed that one about what are the different reporting requirements if registered as a hospital or pharmacy. My understanding is that all pharmacies are required to report naloxone dispensing to the Illinois Prescription Monitoring Program, ILPMP. Inpatient hospital pharmacies may not have an established connection with ILPMP. So anyone can correct me if I'm wrong, but my best understanding of this is if you were distributing naloxone that someone had prescribed to them, and they're then getting the naloxone from the pharmacy because they're filling a prescription, that goes in the PMP. If you're distributing naloxone that was not specifically prescribed and you're handing out naloxone that you got from IDHS, Division of Substance Use Prevention and Recovery, our drug overdose prevention program, then you report that to us through our Illinois Saves Overdose reporting portal. So the difference is whether you're filling a prescription through the pharmacy versus if it's more like generalized distribution with the naloxone that you got from us.
And then this question, is there any legal liability assumed by the ED or anyone that signs up for DOPP if participating or not participating? Example, storage or outdates, distribution, etc.
It is not, I don't know how to best answer this in terms of legal liability, but I will say like it is not mandated for all hospitals, all emergency departments to participate in the drug overdose prevention program. We encourage it because we know how prevalent it is for somebody to come into an emergency department who experienced an overdose and who we would want to take naloxone home with them once they are treated. And I should also emphasize the purpose of the drug overdose prevention program is to order naloxone to distribute. And so you would not use the naloxone you get from our program on a patient that has entered the emergency department with an overdose. You would use what is purchased, the supplies purchased by the hospital to use in the hospital. But then the goal of this program is that you would have naloxone kits that you could send that patient home with when they're discharged. And so it is there for that reason, if you are handing that out, yes, you would want to be mindful if something's outdated. But if Autumn and Hannah, you could remind me later, I can send information about storage, like what's best practices. I know that Narcan actually has a shelf life beyond its expiration date, but I don't remember exactly what is the approved threshold. So I think though, if you see your naloxone is expired, you can order more that is newer and unexpired. And so we do also have some information about what is the appropriate disposal practices of naloxone. And then distribution, I think that as long there's no statewide policy that restricts you from distributing. And so it's a matter of if your hospital does not have any established policies or practices or guidelines, then you may want to work that through with your local hospital, because I know every hospital has its own policies.
And does a doctor have to place, I know this has come up, some of these, this isn't in the chat, but does a doctor have to place an order for naloxone, and does it have to be kept in the Pyxis? And that might be specific.
So this is more tied to like the PMP part too. So like when, and I probably wouldn't, I don't know that I'm the best person to answer that question, but I think that if a doctor is normally prescribing naloxone along with an opioid, I wouldn't say stop doing that. I think like they could still do that. This is more so that we break down that barrier, we address the barrier of people are often not filling those prescriptions, and they feel stigmatized going to the pharmacy and requesting it. And so if it's just handed out to them and they don't have to fill the prescription, then they're more likely to take it home. And so it doesn't mean that doctors should stop prescribing that if that's in their best practices. It just means that this is another way that patients are able to access the naloxone without having to fill a prescription.
Yeah. Okay. So if they are using the DOPP program's naloxone, does the doctor have to put that as an order in, or can the free naloxone that they're getting through the program just be given to the patient?
We don't have any requirements at the
Yeah.
state level that says a doctor has to do that. Now, I don't know if the hospitals would have local policies that would require that. All that we require is that you tell us how many total kits did you distribute per month.
Okay. And then there's a question. I don't know if Tran, if you're still on and would be able to answer this. Are there any patient specific labeling requirements when dispensing upon hospital discharge other than the pre-printed instructions on the box? I know I've heard a lot about this with pharmacy and I don't really totally understand it and can't say I can speak to it very well. I don't know if she's still on. But from what I've heard from her in the past, and she's the co-chair of the naloxone project and is a pharmacist, that labeling requirement is naloxone is excluded from that requirement. So that is not a requirement. Is that your understanding as well, Samantha?
Yeah, I'm not aware of any patient-specific labeling requirements. And I don't know if you mean in terms of there's already instructions on the box and in the box. I think it's more like we want to know that ideally you're handing the Narcan kit to a patient and providing them with that overdose education, but it doesn't necessarily have to mean that you're like sticking something on the box with that overdose education, because it could just be a quick even when we have street outreach staff that do overdose education, we know it's often in the form of like 1 to 2 minutes because of lack of time. But I think like just a short rundown of what are the signs someone's experiencing an overdose and what, like, how do you respond? And in a lot of cases, you may see that there are people that have come into the hospital more than once and you're distributing Narcan. So I also don't think that every person coming in with an overdose would need like the full education every single time. But I see Steve has his hand up.
Yeah. Go ahead, Steve. We can't hear you if you're talking.
Okay.
There
Sorry,
you go. I can hear
I
you.
heard my before and I couldn't. Oh no. Okay. Sorry. My understanding is the same, Hannah, in hearing many conversations with Tran, that the labeling problem sort of got resolved years ago. So really, I don't think there's a labeling issue. And I think it even got easier last year when Narcan became over the counter. I heard a lot of pharmacy pushback was sort of eliminated with that change. So I think labeling is a non-issue.
Great, thank you. I did see in the chat, it looks like Samantha answered it, but there was a question, do we need to report through the online portal only, or is emailing a monthly report appropriate still? Just through that online, how we showed which this was reported. So if you missed that part, you can go back and look, and there is a video on the IDHS website showing how to report now because it's been updated. So there's, like Samantha said in the chat, there's no need to email the spreadsheets now. And I think that's...
Hannah, someone had private chatted me, so I just want to make sure. All the hospitals in the state of Illinois, when we think about the perinatal system, are divided up into different administrative perinatal centers. Hannah and I did just get a spreadsheet from Nikki showing us which hospitals are an approved DOPP and which are not. So those of you that are from the APCs, or if you're like in a hospital and you're like, I don't know if we're a DOPP or not, you can always reach out to your APC because we will be sharing that with the administrative perinatal centers in December of like which other hospitals are approved and which are not. And then, the APC and both the Narcan project, the naloxone project, we can help you guys get to that point. So feel free to reach out to the APC if you don't know or if you need help.
Yeah, something I have found when asking like my own hospitals, especially our level zeros, is talking to them about this and them saying, oh no, we don't have that. And then it comes about that they are signed up, but there's a disconnect between whether it's pharmacy has signed them up, but the staff are unaware. So I think there's definitely room for improvement with that communication, and we're definitely here to help. So that concludes our session unless
I see someone, Joy, I think someone raised their hand.
Okay. Yeah.
It is Joy.
Hi,
Thank
Joy.
you so much for this, because I've really been wanting to do this at St. Bernard. I think I expressed that to Autumn, that it's pretty much a community dissatisfier that we do not, as we sit right in the heart of Inglewood. Couple of questions. One, I've already signed up for the DOPP program because this is a passion project of mine. I know this is your talk was kind of perinatal, but I got this question because I'm at level 0 perinatal center ED. I was also thinking about the vending machines I think how I'm trying to work this question is, if I did do that, I would still have to report off the amount that I passed out. I wanted to put the vending machine in both the ACC building here in St. Bernard as well as the ED entrance. I would still have to report the number we pass off to those Narcan kits, correct?
Correct. And so I'll have a two-part answer. So I'm assuming that your hospital has the funding for a vending machine, but I also just want to address that because sometimes we get questions about whether we cover those costs. We do not. We only cover the costs of the naloxone. And when you distribute through a vending machine, or you have them in the basket out in the waiting room or anything like that, usually what we see people do is they just count how many they put out there. And then when they have to restock, they count how many are there now and subtract. And then that's what they report as what was distributed. So
that's so great. That's so helpful.
Yeah. Now keep in mind that means it's only being distributed and there's no education that comes along with it, which we understand happens sometimes, but we've seen other organizations that they'll maybe put a flyer on the vending machine with some of that like overdose recognition and response information, just to make sure that there's some touch point where they're getting that education. But there's also some information on the Narcan box, we know, but just a suggestion that you may want to consider is if there's like an educational resource that you can possibly put up. And I think that Emergent, which manufactures Narcan, they also have resources on their website that I can look for and put in the chat. And then there might even be something you could just print out and put on there.
So thank you. What I was going to do is print out a form for the ones that we put in the vending machines, and we also are going to have it in the Pyxis here in the ED for face-to-face education for patients that come in with substance use disorder, because we're also creating a Suboxone program here as well. And lastly, yes, because it's a passion project of mine, I took this to our board and they are funding 3 vending machines for me.
That's awesome. I also want to encourage that those that are enrolled, like we do have a zip code field. It is not required, but strongly encouraged. And the reason I bring that up is, Joy, you mentioned Inglewood. Like we are using that zip code level data to see if we are distributing in communities that are disproportionately impacted by overdoses. And so that zip code data for distribution helps us see, like, if this community has high rates of overdoses, are we also seeing high counts of distribution? Because if not, then we need to pay more attention to it, and we need to do more outreach and naloxone distribution in those areas. So when you know the zip code, which I would think is usually the hospital in which you're working, please do plug that zip code in, just so that we can get better data on what that distribution looks like at the zip code level.
Got it. Thank you.
Awesome. Thank you. Nikki King, she's the project manager for the naloxone project, just put in the chat. For those vending machines, a lot of states do put QR codes on them that have the link to how-to videos. So it's another idea. So if you guys, thank you for attending. If you can please take this evaluation, not only just for your contact hour, but it really does help us to see the responses as we continue to collect data, and then also see where more help is needed. So if you answered a question that you do want follow up or help, we will reach out to you. So please just take the evaluation. It would be super helpful to us. And thank you again for attending.